This session will be a very interesting one for all of us, I think. We have Dr. Marc Thiessen here, who's a local oncologist who's really representing mainstream oncology, and he's going to help us. He's going to help us to learn how through his work of surviving the cancer system from his perspective. And as we're going through this, lots of questions will come up about how this works with orthomolecular or IVC and what they're doing at the Riordan Clinic. And Dr. Thiessen will speak a bit about his practice and his affiliations, and then get into the presentation. So there will be opportunity, because Dr. Thiessen will not be here for the panel at the end of the day. We're going to, we're prepared to have questions throughout his presentation. So we have 2 microphones that will be passed down from this aisle and from this aisle. So you're welcome to ask a question, raise your hand, and a microphone will be delivered to you. Is that good? Yes? Yep. We're clear? Okay. Dr. Marc Thiessen. Thiessen.
So as he said, I'm an oncologist. I work some here in Wichita, some in western Kansas, in Great Bend and Garden City. I've been here in Kansas for almost 20 years. I did my training back east. I'm originally from New Jersey. Mom and Dad are from New York City. And I did my training both at Rutgers University in New Jersey and I have a master's in pharmacology from Oral Roberts University. It's a master's in molecular pharmacology. And I did my internal medicine training at Brown University in Rhode Island, and I did my oncology training at the NCI in Bethesda, Maryland. And with that all along, you get sort of to meet different people along the way and interact with different people. And my master's degree thesis was done with a man at Oral Roberts in Tulsa, a guy named Harold Harder, who was postdoctoral fellow in the lab that discovered platinum. People use platinum chemotherapy for all sorts of things, but so you met them. And in Brown University in Rhode Island, I worked with a guy named Paul Calabrese, who was one of the founders of oncology. And so you get to meet different groups of people along the way. And at the NCI, the very first cancer that was cured, metastatic cancer that was cured, was Hodgkin's lymphoma. And as part of our training, you had to follow some of those original patients. So I got to meet the patients that were on the original MOP protocol that cured metastatic Hodgkin's disease. So kind of been around different places and seen different things. Like I said, originally from New Jersey, but I've been in Kansas. I make my home in Hutchinson and been there since '93. I have 3 kids. And if you really want to know Kansas, I know one person here, Dr. Sullivan's done this, but if you really want to know Kansas, you can't really know it until you do the bike ride. Yeah. And people who've been on the ride know that, and I've done that twice, the bike ride across Kansas, and it's a 500-mile, 8-day trip. You do about 75 miles a day, and you get to meet people and meet your patients and see their homes and communities. And I remember one day we were in Hill City, Kansas, and hail started coming down, and I knew the lady had to be a nice lady. She had this little sign out in front of her house, and so 35 of us sat in her garage while a big thunderstorm came by, and kind of a fun thing to do. So plug in for the bike ride. I did it the hard way, though. The bike across Kansas, you could do it. People do it. There's a 9-year-old who does it, a 90-year-old who does it. There's people well in their 80s who do the bike ride. But I did it the hardest way, which was with 2 teenagers.
Are we there yet?
Yeah, are we there? Yeah, kind of moody, but it's so it's kind of and as part, I work for a Central Care Cancer Center, which has offices all throughout Kansas, and I work in many offices. I see people from all over the western part of the state, all over many parts of the state. We work carefully with our university colleagues up at KU. We are involved in the Midwest Cancer Alliance, and I did meet with Dr. Sullivan, who was one of your speakers yesterday, and we have worked with their group on patients and their group on patients that have been on IV vitamin C treatments, and we've worked with Dr. Ron and Jennifer on other patients that we've shared with them. And as our office tries to not very heavily try to not discriminate on patients we see in any populations. We try very hard to see patients regardless of their ability to pay. And the woman I work with in central care, Dr. Claudia Prestamel, feels very strongly about that. And for example, in Garden City, we see many populations of undocumented people or people with underinsured or elderly. And so we see a broad spectrum of population of people. And some of the population that we see that's, different populations are some are stigmatized or discriminated against in certain ways, and we try to have a very transparent, open door relationship with patients and their providers. Where I work in Western Kansas, there's many patients that don't have primary care providers, and so we often serve that role too. Try not to, but we do. And I am involved in the research arm of KU, the Midwest Cancer Alliance. And with that, we can offer patients, through that Midwest Cancer Alliance, that we can offer patients all throughout our area enrollment in clinical trials through the NCI and through cooperative groups. And we can also offer them second opinions and telemedicine consultations. So that kind of helps. The patients oftentimes are very modest means and can't travel far away for consultations, and so it helps them to get access to care they wouldn't earlier get. And within the research arm of KU, the Midwest Cancer Alliance, the outreach, they encourage us to be heavily involved in the selection of which studies are available to us. So the studies have to reach the population that's there. And as we go through this discussion, I'd like to have it be a two-way street, a discussion. If anyone has any questions of any sort, just raise your hand or blurt it out or whatever, and it'll be fine. As part of my practice, it's a very busy practice. I had about 8,000 visits, encounters a year for the last 10 years or so. So we see a lot of patients, a lot of interaction, far more comfortable one-on-one with the cancer patient, whether they speak English or not, whether they're elderly or not, than I am in front of a group of you guys, but that's okay. So see a lot of patients, a lot of experience, and work with university, work with research arm, work with people here at the Riordan Center, and we know all sorts of stuff about treatment guidelines and the boxes and the rules we're supposed to fit in. And I was visiting with Dr. Carter about that, and that needs to be part of your understanding of where the community oncologist is coming from, about treatment guidelines and Medicare and audits and those sort of things. I have friends at the NCI and all sorts of MD Anderson and KU and different acquaintances at different places, and have visited with them in recent days about this talk. One of the men I did training with, and in fact he's a bicyclist too, is a guy named Bill Dayhut. He's the clinical director at the NCI. He and I trained together. And with that, there's the NCI itself has an office of what they label complementary alternative medicine. They didn't say integrated medicine, they said complementary alternative medicine. And there's also a separate larger office at the NCI National Center of Alternative Medicine, which is a much larger facility that runs its own studies. And so that's sort of my background and where I'm coming from. And I had discussed by email and others with Dr. Honeyhockey his wishes for our talk and our discussion. and I know that he couldn't be here because of his family issues. So a couple years ago, I went about this project because a lot of my patients come in, they get treated, they come, they get diagnosed, they get treated, they go through the cancer walk, they may survive, they may not, and you realize a lot of them don't understand the basics about what cancer is and the differences between radiation, different types of chemotherapy drugs, and the stage of their cancer, and many of these things. And as I practice, the way I practice is it's very, very important to me to form a bond and a relationship to the patient that I'm working with. If you can't do that, then there's a lot of fear and intimidation on both sides of that equation. And so the patient's worried and scared and apprehensive about things, and if you're not bonded to the patient, if you don't have some sort of relationship with them where they're trusting and they can ask you even the dumb question, then you worry that you're missing something important. And so I wrote a book, and I wrote the book, and I illustrated it with real-life patient stories. So it would be anecdotal, the patients would understand that I can relate to a patient named Trudy and what happened to her and this sort of thing. And it's important to me that patients can come in, can ask a dumb question, and one of the nurses I was working with just yesterday, and patient didn't make their appointment and needed to come in as a breast cancer patient, and the nurse said, we didn't have this drug approved or we didn't have that approved. And I said, I want to see the patient anyway. I want to see them and engage with them and make sure they know the plan, I know what they're doing. And we all make so many assumptions in how we deal with patients. And one example of what had happened, this happened 10 years ago to a patient I knew that was an ovarian cancer patient. The patient went through the standard surgery, had a great surgery, an operation, expected to respond to further treatment for chemotherapy at a later time. But she went home on a Thursday, and on a Friday she called another office, the guy who did the procedure called his office and spoke to a nurse and said, she called in and she complained of having diarrhea. And so the doc, through the nurse, the doc called in treatment for diarrhea. And the next day on a Saturday, she came to the emergency room and she couldn't breathe and she was unresponsive. And the interpretation of what she meant to say when she was having diarrhea was, my big fat leg is so swollen and I'm so short of breath that I can't make it to the bathroom on time. I lose my bowels over the floor. And she had a blood clot in the leg that had moved to her lungs and she passed away from that. So it's real important to see them, have that relationship where you trust them, where you can actually engage with them, have a good relationship with them. And so that's kind of why I wrote the book, is to make sure that patients could have sort of a guideline to get through the system. And it's very complicated for patients to know, where do I go to get treated? Do I stay here? Do I go to a big center in Houston? Do I go on a study? Do I not? And for patients, I try best I can to explain this. I guess one more part of background is I think docs who have a personal, close relationship to their diseases are more engaged in, as Dr. Carter and I were talking about, there's docs who are engaged with their patients, who are this is their life, this is what they do, this is engaged, and docs who are just filling in sort of the boxes and just checking off this and checking off that. And I've had a cousin who died of cancer at 31. He died a couple years ago. And the girl I dated in college was 29 when she passed from cervical cancer. So so I've had a lot of close connections to people at a very young age that passed away. The red comments here were Dr. Ron's comments. And so the black is mine, the red is his. And for the patients that we see, as patients come to see us, different people come with different attitudes, and some patients come with an attitude of, you're the doc and I trust you and whatever you want to do is fine. Some patients come with an attitude of they've researched things through the internet and they're the junior oncologists and they know what to do. And so it seems to me that if we have a working relationship, that there's a trust relationship both ways, that works best. And I know Dr. Ron's comments here, was there room for the co-learner in modern cancer care? And I think there is. There's the treatment algorithms that we have for cancer. If you take kidney cancer or Hodgkin's lymphoma, any of these things, if these algorithms and plans were perfect, then we wouldn't have people dying of the disease. It'd be more of a chronic disease or a cured thing. So I think there definitely is room, and I think that as we treat people together, as the community oncologists and integrative people treat people together, it needs to be a transparent thing. We need to know what you're doing. You need to know what we're doing. We need to each know each other's treatments and plans so there's no contraindications. I know Dr. Ron had a comment here about, do oncologists dread patients who want to be involved in cancer care decisions? And I don't think that's the case. I think some oncologists are intimidated by that. They have sort of their plan, and here's my plan, here's my schedule, and I think it depends on which oncologist you have. And as part of the book that I wrote, there's sort of a example of how the patient can work with their oncologist and develop a better relationship with them, regardless of how your oncologist approaches the situation. So we've tried to give patients examples of ways they could not be, how the patient can be cooperative with the physician, but at the same time let their wishes be known and let the physician know that they're also thinking about things, deliberating about things, and questioning some issues, but not engage in ways that alienate the oncologist. Like, for example, rather than I'll give you an example. There was a patient that I saw who came to us with an advanced cancer. His cancer was lymphoma, and it had spread, and it was one where we had a great research trial for him. And no, it was a lung cancer. It was a lung cancer patient. And we had a good study for him. And he came to us, and he went on study, and it was a study involving a standard drug and a biologic drug. And we gave him his first day's treatment. And they called, and he couldn't make it. He had a 5 days worth of treatment planned, and standard drug, standard chemotherapy with an addition of biologic drug, and couldn't make it. Something happened in his family. A week later, he came back and continued on the treatment, but it was a research trial, clinical trial, and you needed to stay on study protocol pretty closely. And about 3 weeks later, we got a copy of his consultation from the people he had seen up at the Mayo Clinic, second-guessing us and asking them, what should I do to treat my cancer? And so they had seen him. They had known he actually started to study with us. It was the right drug, right treatment, good stuff. He never told us he was going there. He just went. And we got a letter back from them saying they agreed with us. But that's an example way not to engage a relationship with your oncologist. You need to be right up front and say, I understand you're doing this. I want you to be my doctor, but I'm going to go off and get this opinion here, and be upfront. And that way, all my records get to them, all their records get to me. We engage each other, and if you want to choose a different doctor, then I'll forward things to them, and they could be your doctor. Go ahead.
There's a little dilemma in that. We were just discussing. Hello.
Can we get the lab on, please? It's turned on.
Okay. A lot of times, if a patient comes to me and they have, well,
It's on.
hello. And they want to do some integrative type things, like vitamin C or ozone therapies, and if they want to do some alternative integrative treatments, they're afraid that if they say something to their doctor, that he won't take care of them. Mm-hmm. And if they do say something to them, then they don't have the connection. Now, I leave the option to the patient. I don't tell them, don't tell the doctor, because that's their choice. I do tell them that maybe, I think it's important for them to keep a connection with a doctor who can get them into the hospital and they can continue their chemotherapy or whatever else needs to be done. But I also know, and the patient has studied it enough when they come to me, that they know that the integrative medical stuff is going to help them. So how do you solve that dilemma?
You know, that's a great question. Dr. Carter and I were talking about that before, and I'm glad you brought that up, okay? Because there's undoubtedly groups of oncologists or physicians of whatever specialty that find it easier to treat people simply within the box of the standard guidelines, and aren't going to look out, aren't the 20% that are going to say, you know what, we're still not doing a good job with that. We're going to look outside the box into what else can help the patient, regardless of what it is, whether it's acupuncture, massage therapy, or exercise, or not smoking, or no pot, or whatever it is, regardless of what it is. And there's definitely a population of oncologists, and they're going to say, I'm not going to take you, I'm going to drop you, I'm going to not have you be my patient. And for whatever reason. And some of the reasons for that could be it's just easier for them not to engage in that. It's not in the list of standard guidelines. You know, if you go to the guidelines that we often go by are the NCCN guidelines, nccn.org, and those are listed guidelines made by cancer centers, 15 or 20 cancer centers around the country. They list those guidelines. Medicare usually agrees with those, okay? But the oncologist could be worried that if some other treatment not in the guideline is engaged, then if there's a complication or a problem, then he's the one dealing with the hospital, the emergency room, the stuff at night, the acute illness part of it. He might be worried that other therapies might interact with his therapy. He might be worried that there hasn't specifically been a study about this versus, you know, this plus this. And he might not. But I think, in my opinion, it's best if we all know what each other's doing, we all engage each other. You have my phone number, I answer my phone, you know, you can pick it up and call me. But many are not. And I've worked with patients here that have been seen at the NCI, at KU, that have been on integrative therapies and not on integrative therapies. And so it does happen, but there are many that don't. And I think that the point you bring up isn't just relevant to the IV vitamin C population or crowd. That part happens far more than you realize just within the guidelines of what I do. For example, if I'm giving a patient Taxol for lung cancer, and there's Taxol for lung cancer, standard chemotherapy, Taxol for lung cancer, breast cancer, uterus cancer, for many things. And I know that Taxol is a great drug, works good for a lot of people, helps people, but it's kind of hard to take if you do it once a month. It's a big dose, you get aches and pains, your face turns red, it's a lot. But if you get it once a week, don't notice it as much. But there's guidelines that say you can do it weekly for lung cancer, but for ovarian cancer, you do it every 3 weeks. And so that same criticism could come, even if it's not related to your vitamin C, related to yours, you're just not exactly fitting the guidelines. So I think sometimes the reason why other oncologists say we're not going to interact with you is because there's very specific treatment guidelines. And I think the safest way to deal with that issue is, the very safest thing is within the realm of a clinical trial like Dr. Garrett presented with his ovarian information yesterday. That's the very safest. That will lead to all the oncologists saying, here it is, it's on a study, it's approved, or within the realm of where an office like his at the KU, or the office of my friends at the NCI, at the Office of Complementary Alternative Medicine at the NCI, or NCAM, National Complementary Alternative Medicine Office, within the offices of there's some relationship with someone like that that's done it. You could say, hey, we're developing these relationship with these people who are studying this. Did I answer your question?
So maybe give me a bottom line, what do you tell them? What do you still say to the patient? If the patient goes to the doctor.
What do I tell them, or what do you tell them?
Well, what do I tell them, and not you, because you're open-minded, you're in the 20%, but I think it's more than 20, I think it's more than 80% that are not open, that are in the box.
I would ask them to be upfront with it and say, this is what I'm doing, and I want you to know this is what I'm engaged in, and I feel strongly about it. And if their oncologist is not one that's going to work with them, I would have them engage a different oncologist.
Well, I've done this a few times, and patients have gone and told the doctors, because they've already said they're open to other things, and so I've asked them to go ahead and have that doctor call me. Never get a call.
Right, and then it's not surprising that they don't.
And
do they drop the patient?
Just to carry this just a step further, I had a patient who is my cousin, lives in California. He told me he had lung cancer. They started him on Traxol, and we got him on IV vitamin C and homeopathics and poly-MVA and IV ozones, and his cancer resolved. And he says, well, everybody's telling me I don't need all this other stuff. So he quit it, and within 2 months, he just went way downhill. He quit all of our stuff. He only stayed on the Traxol.
Let me ask you guys a question. The standard, okay, so if I ask the audience, is IV vitamin C standard guideline treatment, or is it integrative therapy, complementary therapy, alternative therapy? It's not standard treatment, it's alternative therapy. Agreed. Okay, so I had this discussion with 3 of my friends recently. So vitamin D, a lot of oncologists talk about vitamin D, okay? Recommended dose is 400 a day or 800 if you're a senior. So the chairman of medicine that I know who had a cancer who's now on 50,000 a week, is that complementary? Is that standard therapy?
Standard, they'll accept
It's not standard therapy.
Yeah. But they'll accept that. That's got more credibility than our vitamin C and poly-MVA and
So
ozone.
it's still not guideline driven, it's still not standard guideline. And I think some of the issue that I visited with Dr. Card about this earlier, some of the issue that the oncologist may fear that they're exposed to that might explain some of the behavior that you may not be entirely aware of is some of the Medicare stuff. Is the oncology drugs that we use are all extraordinarily expensive. Almost all of them are $10,000 a month or so. If I give you any of the new kidney cancer pills, Sutent or Nexavar, any of these things are about $10,000 a month. And 2/3 of our population are Medicare people. So some is IV drugs, some are oral drugs, but they're all thousands and thousands of dollars. And there's a big target on our back for Medicare audits. And the way the Medicare audit system works is there's some kid in 8th grade now who has time to go through high school and go through college and get to work for a couple of years who can audit my decision from yesterday. And he can audit that decision. They could say, here's the guideline. And did you follow the guideline? And you go crazy trying to follow these guidelines. And if you didn't follow the guideline, then they can say, we're going to pick these 10 patients and audit those. And say, well, you're outside the guidelines with these 3. Then we're going to extrapolate it to another 100 patients. Then we're going to extrapolate to your whole 8,000 patients last year. And come get all that money back with interest and penalties.
Medicare.
Civil and criminal penalties. So that may be some of where he's coming from is how close am I following these guidelines, and how much do I have to put myself out for the patient? He realizes, just like you and I do, that the guidelines don't cure everybody. But those are the rules that someone imposed on him now within that system. Now, some of us are willing to go out for the patient because we see things, just like that physician who's taking the vitamin D, he realizes that the guideline of 400 a day isn't right. Go ahead.
I have a follow-up ethical question. We treat people with IPT, low-dose chemotherapy. It's been around for 75 plus years. About 300 physicians worldwide use this modality. And to the best of my knowledge, if you follow the guidelines of IPT, nobody has died from IPT. And of course, I get criticized because I use IPT. And then the other day, a friend of mine who's an oncologist, a nice guy, respect him a lot, he gives me an article, and he says, I got a new cancer drug that for colon cancer. So I read it, and he says, well, the study, I forget the name of the drug, and he thinks that IPT is hogwash, and he thinks that's good. And then the placebo says, for the study, that you will live 5 months with placebo, or you will live 6.2 months with a new drug. So I have a hard time wrapping this around my head ethically.
About why his
6.2 months is okay, and my IPT is wrong.
I don't understand it either. I can't answer that as to.
That's a big ethical question, but I think Dr. Fesen should proceed with his presentation a bit more. These are big questions, and I think we've at least dealt with one elephant in the room. So, go ahead.
When one of the first couple of chapters I wrote in the book were related to something that I noticed quite a bit that happened in it. There was a physician who came to see me, a guy I work with every day, who sees cancer, sends us cancer patients all the time, and he's a person in the community, and he came to see me himself having cancer. So he had cancer. And as a great example of this cancer panic syndrome, what I call the sudden cancer panic syndrome, if I tell you today you've got a kidney cancer, and there's a large mass in there, you get tremulous, shaky, you can't make good decisions, things get sort of, you get bewildered about it, there's a huge stress, and I just tried to point out to patients in the first chapter of the book that how that happens, sort of recognize it and see how it affects your ability to make decisions and things, and how it helps to have companions with you to record the questions, how it helps to deal with the oncologist a couple of different ways, a couple of different times, and there's ways that I deal with that in my practice. I think I'm very good at that you recognize as panic, and some patients come in and they sort of take it out on me, they're mad at me, or so like I did it, or they're offended with some of the things I say, and in large part though, there's ways that I deal with the sort of the panic that people come in and try to calm things down, and sort of to as you develop a relationship, realize the patient is panicking, and the patient is really not in a position to make the best decisions. And oftentimes what I'll do is have the patient come in for a number of different visits until you realize that all their questions are answered, making sense, and they can really make an informed decision. And sometimes there's families that help that, families that exacerbate it and worsen it. Sometimes you have to work with other providers. Oftentimes we send people for I send you for a second opinion or third opinion or stuff until we can really have a good understanding of how things need to go and what decision you need to make. But the panic is a big thing, and we try and work carefully with patients on that. I tried to list for our patients in the book the difference between an oncologist who's proactive or reactive, and a lot of things that we teach our children how to learn in school, how to learn in college about problem-solving skills and things. Oncologists these days, as you describe, aren't really interested in that. They just want a cookbook answer. Here's your disease, here's your diagnosis, just follow these things. And you mentioned the phone call, and I don't get phone calls back from a lot of people. I call people, and they don't. And we try not to use those docs too much, but it does help to have a proactive oncologist who's going to research your condition, research your state, and make a difference for you. There's a person I saw out in Garden City, Kansas with a very strange sarcoma. There's an older guy in his upper 80s, and he had this sarcoma that was in his neck. It was pushing against his nerves, affecting his function of his arm. And it could have been treated with aggressive surgery, and anyone in the age of this population, this group, but he's up in his 80s. We're not going to do that. It could have been treated with radiation, but there would have been an extensive amount of radiation would have bothered him. There was some oral medication for him. And so I called and researched all these things for this guy and made some phone calls to some sarcoma friends I had at MD Anderson and found out that there was a oral agent used for other cancers that we can use for this sarcoma, a kidney cancer drug, and $10,000 a month out of pocket is what that costs. And so made a couple more phone calls, and with that found out that at MD Anderson they're doing a study on that drug, and that study involves another similar drug, and that drug on study was free for him. So a lot of phone calls over a couple months' time, but the patient eventually got to where he needed to be and got on a drug that was helpful for him, a reasonable treatment for his age. But patients can tell that sometimes their oncologist isn't going to be the proactive, problem-solving type of guy that they want. And I tried to explain in this part of the book about things that the patient could do to enhance that trust, enhance your relationship even with a physician that doesn't always start that way, such as to active listening. Here's what the oncologist said, repeat it back to them. Avoid nitpicking. If your doctor is 20 minutes late or something, don't start out with, hey, you're 20 minutes late, or you're, little things. And try not to have the dreaded daughter from far away direct things. That's always a dreaded thing if you get the phone call from the daughter far away. And to always keep your doctor in the loop is sort of an example of what I had said before. And if you agree with the treatment plan with the doctor, follow it. You say either we agree with this or you don't, and try to take notes of what's happening to your body and what is going on, and tell the doctor. I saw Dr. Ron made a comment here about education and misinformation, and I tell you, our office is so busy with so many patients. It's hard to deal with misinformation with patients. We try real hard to. We try to give a lot of educational material out, a lot of resources from Cancer Society and National Cancer Institute for information for patients. We try to, when appropriate, put people in studies or involve the university in their care if that's appropriate. We try to have our office be open to phone calls, open-minded to patients and families. There's my cell phone number is on my business card, and so is the email address. And there's a few daughters from far away that email us ahead of time. They're worried about mom. There's a daughter in Oregon that emails us and worried about mom's case. Mom has lung cancer, lives in Kinsley. She's doing good. And so we try to prevent complications and problems and misinformation between us and them as to what our goals of therapy is by working carefully with the families. I do tell the daughter I'd read her emails sooner if she baked me some cookies, and occasionally she bakes cookies and share them with the patients, and so we got a lot of cookies that way. They help with the bike ride. And there's information in the book. I don't think we need to go to this here about the patients and how they go through therapy. Our office tries real hard to support the patients with their finances and their care. And I've worked I've called the insurance commissioner, I've called Prager, I've called Sibelius, I've worked with them on a couple things. And whatever way we can advocate for our patients, we try to. There's in the book, there's a list of different states. There's 25 or 30 different states that have, before Obamacare, had high-risk insurance pools to where a patient's uninsured comes in, uninsured, has no insurance and shows up with an advanced cancer, and if you pay the premiums and pay the co-pays, pay the deductibles, you can get coverage. You get coverage even with pre-existing conditions. And we've even had that for the state of Kansas. We've had patients who are undocumented receive that. It's kind of a good trick. So we've tried to do that, and a lot of short-term crises we try and deal with there. In the book, it describes different stages and grades of the patient, cancers to the patient, so that they understand and patients this is explained to patients in a way that they can understand it using examples of real patients we've treated. Dr. Braun sent me an email. I wanted to answer some of his questions because I'm worried we're running out of time. I want to answer some questions too. When Dr. Honeyhock asked me some questions, he mentioned that some patients reject our treatments, reject standard conventional treatments because of fear of chemotherapy, mistrust of oncologists, or what he called magical thinking regarding natural therapies. And it's interesting, as I worked with the people here at Riordan Center and Dr. Ron, it's kind of a two-way street. We've worked both ways. There's patients that start out with us that we send to him, patients that start out with him that we send to, that he sends to us, and patients that really needed standard conventional therapy, and we're here being helped by the Riordan Center, and he sent to us because he realized there's things that his treatments aren't designed to do, aren't appropriate to do. And patients that we've seen that are on alternative therapies that have very little chance of helping, but they really need to be treated with standard conventional therapies, and he's helped us with some of his consultations. And so there's a large number of patients that do have fear of what we do, a fear of chemotherapy, and I tried to address some of that in my book about how working with the relationship and discussing things, we can prevent a lot of problems, but still patients come in all the time worried that our drugs are going to make them sicker, not better. And I think people like the Riordan Center have helped that quite a bit. And there, Dr. Ron wanted me to address the issue of our patients are afraid to tell the oncologists they're actively engaged in non-conventional care for fear of ridicule or rejection. I think that definitely happens, as you mentioned in your question. And I think it's always best to address that up front and to deal with it transparently. He also said that patients may be engaged in actually dangerous alternative therapies, but won't tell the oncologist. And I try real hard to have patients, whatever they're taking, whatever they're doing, to bring in all the medicines, bring all the information to me, let me go through it all, because I have had patients that have been on fairly simple things that are available at the herbal store or something that one lady came in, her platelet count was low, liver function tests were high, and lots of problems were happening. Didn't have any disease, wasn't being treated for any cancer, just had a blood problem that developed as a result of something. Go through all our medicines and realize something was bothering her. And so I tried to address his issues there. There was I think it's important to realize that where the conventional oncologist is coming from is part of when you go off the reservation, when you go off of standard treatments, the conventional oncologist is greatly worried about the fear of scrutiny as far as guidelines, licensure, Medicare, Board of Healing Arts, those sort of things. I think that's some of where they're coming from, is those issues. And I think the more transparent we are, the more understanding of each other we are, the better things are. And definitely if there's studies available, like the one that was that Dr. Sullivan mentioned through KU, that helps. I think it's important for the patients to understand, to be very upfront with them with what the goals of therapy are, what the goals of our standard treatment is, what the goals of your therapy is, what the goals of vitamin C is. Be very transparent with what we're saying to them, that there's full disclosure there. They're all on the same page. You want me to go through more of the book or answer some questions? Or okay. Some of what we describe in the book relates to the patients in the big cancer center, going down to big cancer center, Texas, or New York, or we send people to places all over the country. And as patients go to these big cancer centers, oftentimes there's sort of tryouts that happen. You have to, there's a selection bias, and the patients have to be a certain level of health to get there. Many of my patients are too sick with an advanced lung cancer, an advanced lymphoma or something. They won't be able to make it to a big cancer center in time because the visit takes a couple weeks to line up, the patient's too sick, can't make the trip, can't travel. And so some of the studies that are done at major cancer centers sort of have that bias that many of the patients in the smaller communities can't get there in time and can't get access to their care because of that logistical considerations. We try real hard to, if that is the case, we begin the best therapy we know here, begin some treatment and get a second opinion as the patient improves. So we've tried to do that for many patients. And we've tried to work carefully with major cancer centers to understanding what they want us to do for second opinions and stuff. For example, many oncologists are not open to treating sarcomas, advanced muscle cancers and soft tissue cancers. And we have experience doing that, and I've worked carefully to develop a relationship with a number of different experts in major centers because these therapies can often go on for quite some time and are quite burdensome if the patient has to travel. There's radiation, there's chemotherapy involved. And so we've tried to make it so the patient can use the expertise at major cancer centers, but there isn't the resource expenditure where the patient is bankrupting themselves and their families' resources just by being treated at a major cancer center. If they can get the same kind of care closer to home, we try to make that available to them. We try to describe when issues about physician access and, like you said, about can the patient get access to physician at their own cancer center. And if there's issues that I can address, that only I can address, what's the big picture? What are we doing to treat your cancer? We do that, but many patients use the resources of our nurses or nurse practitioners, and oftentimes they feel less intimidated taking the time of the nurse or nurse practitioner. So we try to make sure the patient's questions are answered. All of our patients that get treated, we call them the next day, we call them the day after. We should make sure they have a nurse and an individual name of someone that they can call if they have questions. And we try and reassure a patient that if they need to go to a major cancer center, when is the right time, when is the appropriate time, and make sure that they have good communication with us, that the doctors at the major cancer center have the information they need. It's a very complicated thing to do to send someone off that you've been treated. A lot of records, a lot of information, a lot of CDs, discs. And so oftentimes you'll send that ahead, all get lost, so we duplicate it and get the patient a handwritten copy of all that to try and cooperate the best we can. For our patients, we try to make sure they know what their insurance is all about and how that all matters. There's a lot of our population is elderly and Medicare, and patients often don't understand that, physicians don't understand it, and there's often problems with the population we serve that the patient can't get access to care. If a patient's in a nursing home or a skilled nursing facility, oftentimes they can't get access to the chemotherapy that we're trying to give them. Another reason why sometimes patients are dropped from their other physicians is because they didn't stay on top of their bills, got sent to collection, or there were denials. Denials are oftentimes there's confusion between the provider and the insurer as to why we're doing some treatment. I've never seen a denial because the patient was on vitamin C, though, because of IV vitamin C. And then outside consultants, we encourage patients to use outside consultants. We never discourage it. Some oncologists do. We've always encouraged that, always tried to have a good relationship and to be open. Ron had a question about, given the widespread use of alternative treatments utilized by most cancer patients, do you believe that oncologists will ever receive special education courses in the value of these treatments before they reject them outright? And as I'm studying now for recertification for boards, I haven't seen that come up, but I did discuss that issue with Dr. Dehut, who's my friend at clinical director at the NCI, and he hadn't seen that come up either as far as educational courses. But as integrative therapies become more mainstream and as they're on clinical trials, I think that may be something that does come up. Other avenues might be if some of these questions that he had might be ones that at another seminar you guys might want to involve some of the physicians and speakers from places like those offices at the NCI. Might be a good idea. Anybody have any questions about anything?
I'm wondering if you can just go through the process of how you do work with the Riordan Clinic with Dr. Kohlmeyer, Dr. Hunningham.
You know, we've had patients that have, they've seen that patients that have been not seen by community oncologists have been not willing to see them because they're on vitamin C or other therapies. And we've engaged those patients and treated those patients and work carefully together and make sure they know what we're doing, we know what they're doing, make sure our records transfer to each other. And with Dr. Hunningham, and then there's patients that we've seen that we thought would be benefit by seeing Dr. Kohlmeyer or Dr. Riordan or Dr. Hunningham, and have sent to them to help explain to them the whole world of alternative medicine or complementary therapy, even vitamin levels, to check sort of things. We thought they'd benefit from consultation, and we've sent them those patients.
Do you, as an oncologist, do any of the integrative medical things, or do you stay within the box too, but just accept?
There are patients that are far out in western Kansas that have been through the system at KU that are being treated up at KU with vitamin C that we gave out there because they couldn't travel all that distance. But largely it was our office administering therapies that were ordered by the physician at the university.
But you don't do any of the integrative
No,
treatments.
I don't do
You just
that.
do mainline
Right.
stuff. You just are different in the sense that you accept alternative.
Right, and
as
we've
an
treated them.
adjunct.
Right, we've treated them with their instructions, but it was their physicians that were the ones managing that.
Yes, I have a question. I'm Dr. Richardson from Atlanta, Georgia. I do know of an oncologist who is open-minded in Atlanta, and I send people to them, and he may offer them chemo or whatever he thinks might be indicated. He will follow them along many times, whether they do that treatment or not. So would an oncologist be in trouble with the systems that you talk about if the patient does not want to do a particular therapy in the box? I mean, if it's not his decision, I mean, it's really the patient's decision to me.
Right, I try real hard to explain to the patient what our options are for their therapy. This therapy, that therapy, no therapy. I try to explain very carefully what our options are for their treatment. What I recommend, what I would suggest, what the best option would be, maybe this has this side effects, that has that side effects, and whatever they decide, we'll follow the patient. I don't want to abandon them from our care. We'll continue to care for the patient. We'll continue to see them. They may do something different than what I agree. It may be no therapy. It may continue to smoke something, whatever, or do this. We're going to do whatever they want. We'll help them get that. I won't drop them from our care.
A lot of doctors won't drop them.
Yeah, most. I mean,
If you were to sit as an oncologist, judging an alternative physician that practices alternative oncology, what would you like to know from me if I'm practicing within satisfactory parameters?
In the individual patient, what would I need to know?
Individual patient.
Exactly what you're doing, exactly what drugs we're doing, exactly what treatments, what the goals of therapy are, what the patient understands the goals of therapy to be, and what you'd like our role to be.
So that would be satisfactory to the board of examiners then if you did things with certain parameters. I'm looking for the parameters. What are the parameters that I'm allowed to practice integrative cancer care without being persecuted?
That's kind of a hard question to answer.
Are there any other questions for Dr.? Thank you.
With respect to giving intravenous vitamin C, how close would you allow it to be given to chemotherapy? How close, within hours or within days or within minutes?
We try to have a different day. Try to use it a different day. Oftentimes patients seem to get fatigued from either our therapy or your therapy. It seems to be if you have it on a not scheduled the same day, it seems to work best.
What is the scientific logic behind that?
Say that again?
What is the logic behind separating chemo from vitamin C?
Simply just a functional one. Patients had a big day. They get fatigued and tired from having a whole day seeing me, and same thing with you. There's no other logic other than that. It's this office takes a day or so to get in and out, and here my office just there may be a better logic to doing it together.
Yeah, well, we were having this discussion this morning because obviously intravenous C in very high doses at the tissue interface, at the cancer tissue interface, is a pro-oxidant, which would then benefit the work of those chemo drugs that are pro-oxidative. But the thought was, while it's still in the blood, it's possibly still an antioxidant. And my question is, could it then, if you were giving it at the same time, somehow interfere with chemo?
I've had discussions like that with Dr. Ray Perez up at the university. He's a new phase 1 expert they have up there. And I think the best way to handle those sort of issues is ask someone like him. He does phase 1 clinical trials. Ask someone like Ray Perez up at KU to set up a specific study as to, does that matter? Does that affect treatment outcomes by scheduling it the same day or different day? Right now it's just kind of random according to the schedule and what works best to not fatigue the patient. But I think that's the way to do that, is through a university trial like that.
Thanks very much.
I think we can close this part of the afternoon session and thank Dr. Fesen for his presentation, and I hope you have felt at home here, Dr. Fesen, because we really appreciate it.